All right, today we're here with Dr. Curcio, and our conversation today has to do with documentation, all the benefits and drawbacks that it comes with. So, Doc, thanks so much for joining us today.
Thanks for having me.
All right, so give us a quick introduction about what we're going to be going over today.
So, this is a lecture that I put together. It's called Documentation Pearls and Pitfalls. And it's just to help with a good foundation of documentation. I think, unfortunately, documentation is everybody's favorite topic. Not really. And so we sometimes minimize the importance of it because it's more of a hassle, and I get it too, right? Like on a busy emergency department shift, the last thing I want to do is, you know, more documentation, right? But it is very important to, and we'll go more into why. But we just need to like to give some pearls and pitfalls to as a good general overview that you can use as you proceed, with your patient care.
Very good. All right, I will pull up our PowerPoint. We can jump right into it.
Okay.
All right, go ahead.
All right. So I think anytime we are talking about something, or you always have to ask yourself, like, why do we do it in the first place? And most people always think like legalities, right? Like, I got to protect myself whenever I'm on the stand. But that's actually not one of the reasons why we document. There's three main reasons. So, number one is the patient care report, right? It's the only written record of what you are doing on the call. So it's becoming a part of, and it does become a part of the emergency department chart, right? So the other healthcare providers can look back to see like how you intubated or what the rhythm actually was or what the EKG initially showed. And so it's super important to make sure that from that perspective, your record is complete. The second reason is for quality improvement in EMS research. So and we'll go more into why with that, but this, we have to report to the state certain things, and we have to continue per the state review runs and focus on our quality of care. And so if it's not accurately documented in the chart, how are we knowing if we're giving standard of care? And then the third thing is insurance reimbursement. I think, unfortunately, when paper charts were going away, insurance reimbursement was the main reason why we were doing electronic charting. And so especially some of the older providers are thinking like, I just am doing this so that we can bill. Yes, unfortunately, some of it is the nature of the beast, just like in the emergency department, certain we have to get paid for the care that we provide, and our documentation does that. So we're going to start with that. Yeah, start with that first, because this is actually a table from Nancy Caroline's book, if you guys remember, like paramedic school or whatever. But just things that you should be writing in your considering when you are documenting. Having the appropriate signatures in the right spot, making sure that all your procedures are documented. We don't necessarily need to obtain insurance codes, but and then the biggest thing too is like why they needed ambulance transport, which in some scenarios you're like, they probably don't. But if you are transporting, I think a big thing that we've seen or has seen is the patient riding on the bench, but there's no reason for why the patient is riding on the bench. So if they need, it seems really silly, but if they need ambulance transport, then they should be in the cot. But we know there are some patients, whether that's like an autistic child or an autistic adult, whether or not the patient's drunk and you don't want to get into a fight with allowing them to sit on the bench. And that's just something that needs to be written about more in your narrative of why that happened. The second, I would say going from like least important to most important is quality improvement. We have a pretty impressive QI program here using First Watch as well as peer review and ESL. And so if it's not, First Watch is a computer algorithm. And so it does look for certain benchmarks, like, are we giving aspirin on our chest pains, like STEMIs? Are we getting an EKG? Are we getting multiple vital signs? And so we want to provide good care. And if it's not documented, then it didn't happen.
How is, if you don't mind me jumping in real quick,
Mhm.
how is First Watch actually utilized? And that's not something we always get return of information in the field. Is that all just done in the background?
I think, yeah. So just it is a program that and honestly, like I don't have an account yet. I'm working on it. Um, but um, our runs are fed into this system. And so based on algorithms of, based on, I would say like chest pain is the easiest one, getting an EKG. If that isn't obtained or in the PCR chart, then it will get kind of flagged like, hey,
Okay.
we didn't act within our protocol.
Okay.
And so then we can always look at the actual narrative and look at the PCR because maybe there's a reason for why we didn't do it. And, every run is different, but at least it will let us know like, hey, here's like a one off. We need to dig deeper. Why didn't we get an EKG on a chest pain?
Sure.
Or same thing like a blood glucose in a stroke patient. So those sort of benchmarkings that we would want to see. That's like good standard of care.
Awesome.
The other thing too to consider is, with flowchart treatments, and we'll get into why this is important too. But let's say we're having, a rash of like poor intubations. Well, then we can see like, all right, what are we using? How are we doing it? Are we using video versus direct? What meds are we using? And then also like, is it provider based? Have they had a lot of training in intubations? Do we need to do more intubations? So it's really important from that perspective too, of just seeing. And something that I talk about a lot is human error, and quality improvement and human error kind of go hand in hand, right? And just culture. So just culture is being open and honest and non-punitive about human mistakes, because we want to learn from that. And human error, 80% of the problem with human error actually starts with the system. And so having accurate documentation of what happened on the scene, not only talking to the medics of what happened too, allows us to start looking more into a run, or if a mistake happened, and say like, do we need to change protocol? Do we need to change the med box? Is it because we have two orange caps next to each other in the box? And so it's quality improvement is a lot more than just um, going through runs and us getting EKGs. And the better we document, the better we can do from a quality improvement perspective, especially if, error or an accident happened. And finally, the most important thing is that this is the patient care report, okay? And you have to remember that the people that are reading the patient care report aren't always medical, right? Lawyers ask for patient care reports if it's a motor vehicle crash, or God forbid, like an actual, accident, or, poor care, or they think poor care, or families. Also, like domestic violence, child abuse, things like that. So often you are trying to describe something medical to non-medical people. um the second point there is too is like, you're busy, and the person trying to read your report is also somewhat busy, so it's better to keep things simple, right? I would say quantity isn't necessarily important, it's quality of what you're writing. Does what you say have value and add value to describe what happened? And then the whole care report is one document. It has to be like consistent. And the last point is really important. Sloppy writing suggests sloppy care. And so if you don't pay attention to detail in your report, this is your first impression to whoever is reading it. And so if someone is seeing a lot of mistakes, they're going to be like, man, like this person doesn't care about writing this report. Do they care about doing a good job? If that makes sense, whether that's true or not, and I always learn that it takes 27 other impressions to overturn a bad first impression. So we all go on the runs that are the stub toes, and, like that's not as important, but I would say like the you 90% of the runs that we go on, you really need to pay attention to dotting your I's and crossing your T's. And so when you're writing a narrative, you should, we recommend the chart method, right? Like the chief complaint, history, assessment, treatment, and transport. It does not need to necessarily be bulleted. Here's an example. Like the bulleted method does make it very simple to read and breaks things up, but you can do it in a paragraph format. It just all that information has to be there. And so if you're looking at this, one of the areas that I blacked out, they actually talked about um, what address they were going to. And if you get anything from this talk too, is ESO is a really robust platform like EPCR. You have to fill out like a lot of different things. And back in the day when chart was developed, you didn't have these robust PCRs that already had areas to put all your treatments or anything. So you had to write more in the narrative to begin with. So chart has kind of come through the time to the future where people are still using it, and it's a very easy way to organize your thoughts, but it's okay to like leave out parts of it if it's being written in ESO somewhere else. And so you don't need to rewrite where you were dispatched to because it's already in your scene address. um Something else on this one that I thought is like IV's access was established with a 20 gauge and the left AC followed by 10 C flush. You know, don't, I mean, that should be in your treatment portion. And so save yourself some time. You don't need to, when you're doing a procedure, that's already in the treatment portion, talking about where you placed your IV, whether it was successful or not successful, if you gave a flush. And so you don't have to describe the procedures in your narrative. Here's another.
So before you switch
Yep.
out on that, we talked off air before we came
Mhm.
on about historically we were told we had to write the treatments in the narrative because of billing.
Mhm.
Are we going away from that? And then you're saying that at this time it's okay to maybe leave those out in lieu of summarization. How do you want us to approach that?
Yeah, so I asked about whether or not that was something that we needed to do, and my response back I got was that you don't have to list out everything. And so I'll show another example here. We're going to go to that screenshot um, where it's listed here, all these treatments that were performed. Also, like, weight.
Can you zoom in on that a little bit just to help
Uh,
us out?
yeah. So it talks about all the treatments, trauma assessment, manual C-spine immobilization, C-collar bleeding. Okay. And then it also talked about the weight, which there's an area of ESO where you could have the weight, and then intubation with all the proper techniques, confirm proper placement. And so, absent epigastric sounds. And so if I'll go to this other, back to my slide here, um, all that information, the weight is in the patient portion, but all that information is already listed. And they did such a great job of listing all their treatments. And it's like, this was already a complicated run. You know, you don't need to relist out everything. And we'll talk about something with like how it needs to be a consistent, cohesive uh, one document, and that's everything, right? That's your demographics, that's your treatment portion, those are your vital signs, that's your assessment, and then it's your narrative. And if there's ever an area where two areas disagree, well, now they're like, are they paying attention? Did they give 100 mics of fentanyl or 10 mics of fentanyl? Like, did they, you know, like sometimes you can see on the assessment portion, and we'll talk more about parallel structure, but the assessment portion will say head, no abnormalities. But then in the narrative, sometimes the medics go more in detail and be like, had a 2 centimeter laceration. I was like, well, what is it? Was it no abnormalities where in the assessment portion where it's supposed to be, or was there a 2 centimeter laceration? Like, and so then it starts drawing into, well, where else do they have inconsistencies? And so again, if you approach it from a perspective of you're trying to, explain to someone who may be not medical and looking from a whole documentation, less is more if you're utilizing ESO the best way.
Okay.
And so we want the treatments in the treatment section, because also going back to the QI part, a lot of times we can't query the narrative, but we can query, that fentanyl was given because it's in the flowchart treatment. And so I can go back to like QM and ESO and type in ketamine and see all the runs that ketamine was given and who gave it and how much and what like the primary impressions were, because it's in the treatment portion. But if it was just in the narrative, I wouldn't be able to do that. And so it's more important to put things in the appropriate spot of ESO and not necessarily in the narrative.
So one of the kind of random questions would it be more important to screw it up in the narrative and have it redundant in the narrative, or to make sure that it's actually accurate in the treatment section?
So the most important thing I think is making sure it's accurate in the treatment section, and something. And when you go into like I'll go back to the chart, method, the treatments, I think something you can use is just like treatments as listed above,
Okay.
unless it's like a treatment that you need explanation, right? Like patient was on 2 liters nasal cannula, was continually tachypnic. So then we transport it, or we went to CPAP, so then it kind of, that's showing like your thought process of why you went from nasal cannula to non-rebreather to CPAP, because patient was continuing to decline, or what signs or whatever. But if it's just like, for like RSI, like I would just say, treatments that stated above, like intubate the patient based on altered mental status and difficulty to oxygenate, RSI performed per, listed, or per protocol, or something like that. And we can see the order of everything. And we'll go more into like the importance of your clinical timeline too. But
so how do you do that? Because we kind of two different methodologies.
Mhm.
One is to do more of a timeline narrative, and the other one's to do chart.
Mhm.
Obviously, you prefer the chart. Are both acceptable? Is chart the industry standard that we should be moving towards?
So I think, Dr. Gabriel prefers the chart method. And so I defer to him as far as, we should probably try to be consistent across the, like, okay, let's do chart, but chart can be done in a paragraph form as well. Your history, your assessment, and then the treatments kind of will end up, it does kind of follow that timeline.
Okay. So it doesn't necessarily have to be bullet pointed with.
No,
Okay.
it can be a paragraph.
Okay.
And chart kind of naturally follows that timeline as well. But you don't have to, as long as the information is there, you don't have to bullet point it.
Okay.
But kind of would like that flow even in a paragraph. So that's kind of like the foundation of why we document, why documentation is important, and then also like kind of the how the narrative should be kind of should be worded or flow. But let's go through some pitfalls. And the first one is, I think number one would be, clinical timeline doesn't make sense. And so you're going through your treatment and you have, IV midazolam given, but the IV is below the med. And so it's like, okay, well, did they actually give it IV? Is this in the wrong order, or like was it IN midazolam? And so just making sure you to pay attention to that the clinical timeline is actually in the order that the meds are given, especially for like RSI, things like that, paralytic after sedation. And also, that it matches your actual like times at the hospital, things like that. I have seen things happen after the, you're at the hospital. It's like, all right. I mean, there are times where people get intubated kind of on the ramp, like, and then it is what it is, right? You write about why that happened. But you should just really pay attention to, like, the duodenum isn't charted in the treatment portion, and you've been at the hospital for 5 minutes, that just doesn't quite make sense.
I will say, historically speaking, and from somebody that does QC on some of the reports, is had it the other day. The member gets to the hospital, writes the report, clicks, and it auto populates the time. And when you click IV,
Mhm.
and then they don't go back and post date it.
Um,
And if it's before the run is closed out
mhm.
and the call closed time, it won't throw the error. So
Okay.
the if you're doing it for the officers and out of class members, if you're just going by that, make sure you look at those times because it won't show up. It'll allow you to lock that report.
Right. Yeah. ESO is great to a point. It doesn't think of everything, that's
Sure.
for sure. Right. Um, okay. And then this is a big thing too, like the parallel structure, right? So as I talked about before, like the individual sections actually have to be consistent. And that's something that is also really common is people say like vital signs within normal limit, but they're not. Right. And so it's like, okay, well, this, do they know what normal vital signs? And I've actually seen like a transcript of a case, right? And the lawyers hammered the medic on what are normal vital signs. I was like, man, I never thought like that would be something that they would flag so much, but it was an inconsistent statement in the chart and they just tore it apart. So just paying attention to, and sometimes we get into the habit, of just saying like vital signs are within normal, limits, or you get into a flow of what you're normally used to writing. But you have to pause and be like, okay, does this make sense based on what I already have, written? Sometimes for me, I don't really say anything unless there's an abnormality that like it's standing out, like patient is hypoxic 80%, or because that's something that I'm going to act on. Otherwise, I just say like vital signs are as charted above,
Okay.
because then it's just all objective, right? Like here are the vital signs. So unless something is like abnormal that you're acting on, you don't necessarily need to write out in your narrative what the vital signs are.
Something else you had there, and maybe it's just for the training, but you say VSWNO. So
Oh, yeah.
acronyms.
Right.
What's your thoughts on acronyms?
Well, we're gonna get there.
Okay.
So that's using the appropriate acronyms that are approved. We are gonna move to the gold protocol. I don't know if everybody knew that.
Mm-mm.
Oh, well, big news, everybody. We're moving to the gold protocol. We're in the works of doing that.
Live here.
Here, we're gonna drop that right here. And in the back, they actually have like approved acronyms,
Okay.
and that's super important. So when in doubt, write things out. And I did not mean to rhyme there. Something also is utilizing the unable to obtain. And I think people utilize it a lot inappropriately. And it's okay to have blank spots on your vital signs, right? Like sometimes it takes you a minute and all you have is them on the monitor, or all you have is that they're unresponsive and things like that. Not everything needs to be filled in, but unable to be obtained is only when there's like a patient barrier not allowing you to get that vital sign. Not that that doesn't exist, I think, if that makes sense,
Yeah.
right? So this is from a cardiac arrest. And so, blood pressure unable to obtain, it's probably because there's not a blood pressure. And it's okay to put like 0. Or blood glucose unable to be obtained, and that's not true, right? This person is pulseless and apneic. We can get a blood glucose on this patient. You just temperature still. We could get a temperature on this patient. There's no patient barrier. It's just that we don't have one yet, So instead of filling in spots with UTO, it's better just to leave them blank until we actually have that information. Not, yeah, I think that's just a big misconception. And I think on this too, I like where we've had PEA lots of times says like pulse rate indicates Lucas device compression. And we talked about at one of the run reviews, like, do we use what the monitor's telling us? Do we, if it is incongruent with like what we actually feel as a pulse, like someone's in bigeminy and I only feel like 30 beats as a pulse, but the monitor is calling 60. I think if you can leave the numbers in your vital signs, okay, but you need to explain why, like, this is not. So I would say like pulse is 40, they're in PEA, right? Like you should explain like why there's an inconsistency there in your narrative. um Same thing, like pulse is 60 on the monitor, but they're in bigeminy and I feel a pulse of 30. Does that make
It
sense?
does, yeah.
I think that clears up a lot but initially I would put, since this is a cardiac arrest, pulse 0, like, because we don't have them on a monitor yet. They're pulseless and apneic. And same thing, like respiratory rate unable to be obtained, that should be a 0 too, right? They're not breathing. 12, 9, that's now our ventilations. ESO has the ability, you can put like 12 and select ventilations to let you know that you're actually bagging for the patient. But it shouldn't be unable to be obtained. It's 0. Does that make sense too with
It
that?
does. There's a couple of things that I could see being challenges to that, or not challenges, but quirky runs. Is so we're required to do 2 full rounds. I think first pass has a minimum of 2 full rounds of vitals.
Mhm.
Um, if we are, say, I mean, we've transported from the hospital to the hospital at the same building.
Mhm.
Is one of them going to be unable to obtain because of time, or is there? How do we handle that? And then 2 is if something goes undone. I don't know because of time or whatnot, but how do we? There's times we have to be able to lock out the report, but the information doesn't exist. Do we do other reason not indicated or patient refused?
So if a patient refused, then it's okay to use like unable to obtain, because obviously there's a barrier from the patient. Also, like if the patient's super agitated, right, and you can't get a vital sign initially because you have to sedate them or something like that, then that's unable to be obtained. I would say we should strive to get our 2 vital signs as much as possible. And if you don't have them, I wouldn't saying like unable to be obtained, because there's not a truly a barrier from us to be able to do it. It would be that we have 1 set of vital signs. You have to explain why you weren't able to get a second set. I
Yeah.
think that makes more
I
sense.
think
It
the
would
one
be like,
example I have is I get one set of vital
uh,
signs, and then the next one I get, but it's not a full set. Like there's not
mhm,
a blood pressure, let's say, but I do a radial pulse, respirations, and all that kind of stuff. So I have the second
yeah,
line. It's passable, but it won't let me lock it out because I don't fill out the blood pressure, and it
huh,
requires me. There's a few of those when you put in a vital line actually require.
okay.
I don't know if that's
I can't answer that,
okay.
but we can look into that,
Yeah.
because I don't know, because obvious like ESO does have quirks where we can change things and we can make things like mandatory to be able to close out a report.
Mhm.
So we would have to look into why that is, if that is something that, we want to keep, as far as not allowing you, because then you would have to fill it in with something, and that could be why we're creating all these unable to be obtained that you know
Yeah.
unnecessarily, instead of just allowing that to be blank.
So to back up and reinforce your
Uh-huh.
initial point is just to use the unable to obtain specifically for when there's a barrier between you and the patient.
Patient,
Okay.
yeah, like that's the biggest reason for using unable to be obtained. Yes.
Very good.
Autistic patient, patient's combative, patient is refusing. So
Very good.
all right, number 3, the super medic doing it all. There is no way that one person can do like compressions, intubate, place the IVIO, pushing the meds, and sometimes it is a pain to like assign the right person to do things, but it's super important from the QI perspective because, let's say we're going to GlideScope, right? We're going to be able to record our intubations with GlideScope. Like, we want to know, for good or for bad, you need to give credit where credit is due, if that makes sense, right? And also the way we can track like our RSIs, we can track our intubations, we can track our IVs, see how many people have gotten things. So it's just really important that you write who did what in the chart, and that you don't give yourself all the credit from that perspective. Okay, using incorrect terms and abbreviations. And down the bottom is my favorite, or, a lot of people love to use, PEARL, and, PEARL stands for pupils equal reactive to, or pupils are equal, round, reactive to light. And it used to be PEARLA in accommodation, but we don't do that very often. But if you don't know what it means, or if it's not an actual accepted abbreviation, then you really shouldn't use it. Just the other day, I had a stroke alert, and it was for slurred speech, dysarthria, but the nurse put in the triage aphasia. And it's like, well, those are different, right? Aphasia is word finding, expressive aphasia. They don't know it's a pen, or they having trouble to find, but dysarthria is the actual. And I think the neurologic terms are the worst, right? Because I still sometimes feel like, all right, I got to look this one up. Like dysarthria, dysphagia, they're all like just run together. But when in doubt, just, just put the layman's term instead of risking putting the wrong term, and then you again go back to that sloppy writing is sloppy care. This person doesn't know what they're talking about. But Kevin and I were just talking about how the GOLD protocol has like accepted medical abbreviations that you can use. And so that will be much more standardized as we move forward. And this is all very much in very early. So, but yeah, so I don't know when we'll officially move in that direction. I don't know when the timeline, but we are moving in that direction, which is exciting. And so that will help us from this perspective.
So a quick question on that is, when we talk about you're writing out those words and everything in your narrative, but then we also talk about the, I just blacked out there. We have the patient care and actually the assessment. Do you want us double assessing the patient, writing it out long form in our narrative, or do you want us to put it contusion is actually dot contusion and then put it on their head? Right?
Yeah. So I'd say use ESO to the best of the ability. That like freaking anatomical man is so great, right? You'd be like, gunshot wound, laceration, burn, and it'll fill it all in. I would say it's better to pay attention and do a good assessment in that. And then again, you can do like assessment as stated above, or in a situation where there were some like traumas, which were pretty significant, and that you wanted to talk about how like this is, kind of supporting why you intubated and things like that, then it's okay to go back and repeat yourself a little bit. But I would say that's only for, those cases, those like big runs where you're like, okay, I need to support a little bit more about what we're doing here. Not necessarily the runs where it's just like, okay, abdominal pain. You don't need to repeat yourself. Like I said, I think, keep it simple. The narrative is, quality over quantity in the narrative, and use ESO to its fullest extent. And it's just going to keep everything, back to that parallel structure, very consistent and concise.
Very good.
And then verbiage. So verbiage is really important. Okay. There's so many times where we find ourselves writing like subjective statements about people. And it's important to focus on like, go back to like SOAP back, subjective is what the patient is telling you. Objective is what you find. And so there's two kind of, examples here, the alcoholic clearly intoxicated. Well, you should approach these runs as like an altered mental status patient, right? Slurred speech does not necessarily mean intoxicated. So it's like you can write like patient speech is slurred and stumbled on the way to the medic. They had 6 beers, or they smell of alcohol, right? But you're not saying that they are intoxicated, because it could also be, yeah, they smell of alcohol, but they just fell and hit their head and now they're a head bleed. So be careful from how you write things. Same thing like patient acting crazy and combative, those ketamine runs, or patient that you may need a sedate, just be very objective. Like patient is crying out to Jesus and states he sees the devil on my shoulder and trying to hit it away, and then it's like it supports it. And so here is an example too. Um, it was about this was an agitated patient that we ended up giving Versed, but I thought they did a really good job. From like, was very agitated, confused, try to get a blood pressure, but he would remove the equipment. So you're just telling everybody like exactly what happened, right? Like, we try to do this, we're trying to provide medical care, and he is keeping us from doing that. Like, we weren't able to get IV access, so we gave, the 5 milligrams of Versed, which calmed the pain. And then at that point, we were able, it's like confused as to place and time, got blood glucose. And they were really good at talking about like several small bruises of the belly. And then like observe the patient constantly grabbing his genitals as experiencing a lot of discomfort. This is all just very objective data. It can support like, why is he agitated? Is he having an abdominal process going on? Is he having like a testicular process going on? We don't know. He could just be a very demented man. But it is very objective to like why we did what we did and our concerns from a medical perspective for this patient. This was also very good too. This is someone who had several drinks, but it supported supported kind of like how we weren't just very subjective with our writing. We were very, appear diaphoretic, but then we found out that he was being wiped off with a wet rag. And so they really explained what he said. Says bourbon, it was a lot. So if it is subjective, it's coming from the patient, use your quotations. And so I just thought this was a really good example of not becoming too overly subjective and still remaining that objective medical kind of point of view. Okay. And then finally, refusals. Refusals are always high risk of liability, because for some reason patient is not going with us to the hospital, and we always have to, not a big deal on the stub toe, but for those high risk old patients and multiple comorbidities, possibly at like abnormal vital signs, you just really have to pay attention to what we're writing. And then also, refusals are based on the patient having medical capacity, which is difficult when we run on a lot of nursing facilities with demented people. And then also on their medical capacity to understand their risks based on a full assessment. So that means if someone is having a shortness of breath, their knowledge of their medical scenario, based on the information that you are giving them. And so if it's short of breath, those are the things like, especially if they have clear lung sounds, like it would be good to get an EKG. Like, why are they short of breath? Why do they feel it? Could just be anxiety, but people die and get anxious. So, like getting an EKG, getting an end title, really like, again, crossing your T's, dotting your I's, because then you can provide them all their information, um, and all the risks versus benefits based on what you did in the field, and then they can make a true informed decision to refuse. And a big thing too is, I would say, like those chest pain patients that just want to be checked out, right? They're coming like, oh, I'm having a little chest discomfort and my blood pressure is high, and they roll up to like the station, and you go like, oh, well, you get an EKG and it looks good. and then they think they're fine. But it's important for them to know, like, oh, well, there's two different types of heart attacks, right? There's a STEMI that we see on the EKG, but there's an NSTEMI that we can only rule out with blood work, because people often think just because, my vital signs are looking okay and I didn't EKG, I can't be having a heart attack. And so that's something that really needs to be explained to those patients. This case, you know, overall, I think we did a good job with it, but um, towards the end, it says the resident has dementia, but was and mental status at her normal baseline per facility staff. And then we talk about the resident didn't wish to be transported to the emergency department. And it's like, okay, well, you're telling me that they technically probably don't have medical capacity to refuse. Granted, the next line says, like, facility agreed and stated they may have a faulty SpO2 sensor. But, it's really like, you start thinking like, well, could they refuse? Who's their POA? What is their normal baseline here too? Because I don't think we rewrote about it even in ESO gets a little tricky because in the mental status line in the assessment, you can click like normal status for normal baseline for the patient. And I think if you try to not, once you like try to select which one it is, and like it takes it away, or you can't select like only two, like person and place, then you don't have that normal baseline. It's like inappropriate usage of that term.
Yeah, I think it's under GCS. When you click GCS,
Okay.
you can click normal for patient, or
you can go
no
through
abnormalities, or you can sedated or whatever.
And then you can also do like your 4 kind of actually select which ones it is. And I would just tell everybody just to just get rid of the normal baseline for patient, right? You should write like, okay, this person is oriented this and this. And then in the neurologic section, you could put normal baseline for patient. But in that mental status, you should really expand on like, what is this? Because especially when we're running on a lot of older patients, we need to know, like, and it's important for emergency department too. When you're bringing them to me in the emergency department, I want to know, like, what is their normal orientation and are they now off? Because it's like, am I getting a head CT or am I just going to check their urine? So, but
How do you do the ones where nursing home staff calls you, patient doesn't want to go, but patient is in? So who signs a refusal on that? Obviously you can call medical POA, and can we get a verbal refusal from them? Can the staff sign off a refusal if they decide that the patient then doesn't want to go? Because we get a lot of calls from nursing homes because they had to call. Doctor 4 states away says, well, just call because private took too long. And everybody on scene's like, I don't think this is right. Do we need to, who signs the refusal at that point? The dementia patient or the nurse?
So the dementia patient can't, right? Okay. Like if they don't have medical capacity and they have a medical POA that is, making their decisions and all their decisions. And, ultimately a lot of times those nursing homes also have already talked to the POA and say like this person should go to the hospital or whatever. Then it should be talking. I would say it would either be the nursing home staff that then decides, okay, they don't need to go and they'll sign the refusal acting, or talking to the POA and getting like a verbal, like, okay, this is, from the actual, after like the daughters, like, oh, okay, this is not something, they don't need to go, and they agree to not transporting them. But
yeah,
like it's really, that's like super gray area. Okay. Though. But like I would say if the patient can't make their own medical decisions, then they technically can't sign a refusal.
Okay. We'll have them. I mean, they're all over with the extended care parties, all the way down to they call the doctor, say, the lab work's off or whatever. The patient doesn't want to go to the hospital. The nurse gets send them, it's 3 a.m. I don't care if it's 2-day-old lab work or not. And then the family gets a call saying, our doctor says you're dad needs to go to the doc or the
Mhm.
hospital. And then we get on scene, we will even call the family and they're like, oh, I was just told he needed to go. I didn't know why. And then we explain to them, they're like, yeah, we don't take
Yeah.
him. So I don't know who to send that to for a refusal. Do we just say,
I would say write about it in the narrative,
okay,
obviously. You know, you got to say, like, actually, this is why they're not going. And daughter, who is POA, agrees. And that's something we can look at or talk to Kevin and Troy about. Like, I think then the facility could sign the refusal.
okay,
Or I don't know if it would be like a verbal refusal based on conversation with daughter. I
okay.
don't know the signature.
We can follow that up in a
Yeah.
separate
Yeah, we'll have
email.
to, yeah, like how that would work.
Okay.
But the patient can't. That's the thing, because they're not the ones making their own medical decisions.
Makes sense.
So, the only other thing with this one here is we talked about, like, resident was on 4 liters per nasal cannula, and you just need to know if that's their baseline. Like, was it 82% they put them on 4 liters and this is new, or they're always on 4 liters? So that was the only other thing with this refusal that I was like, oh, we should probably just make sure we document, like, is this abnormality like normal for the patient? And then this was a very good one too. I thought this was great. This was a seizure on an autistic patient. And we just went above and beyond. My mom was like, he gets more agitated if he goes to the emergency department. This was his normal seizures. It didn't last very long. And, we stayed to make sure that patient came to his normal baseline and was able to follow commands, and then we talked about how he was now back to his normal baseline, and mom then signed the refusal as the legal guardian. But I thought this was just such a good run, and that we did such a good job. It's really easy just to be like, all right, peace out. Like, you don't want us anymore, or you don't want him to go to the hospital. But we actually, did a really good job to stay and make sure that, this wasn't a status kind of picture and that he was coming back to his baseline. And so this was a great refusal there too. And so here's quite, this was just a foundational thing of, like, common things that I've done so many run reviews just in, like, the last several years. I mean, I feel like fellowship was a year of run reviews. So I've been in ESO a lot. So these are just kind of things that I've picked up on, but also Michael Holleran is the city of Columbus's attorney, and he had some documentation thing that, I kind of learned from him too, what he sees, and he's a firefighter as well. And so this hopefully can, give you a good foundation moving forward for everything. And if you have any questions, here's my information. You just send them my way. And we have to figure out that signature thing for who to nursing home.
It's okay. It's kind of a one-off thing, but it's a real one that we get. So we'll follow it up by email.
Yeah. Cause I mean, I'm learning we go on a lot of nursing homes.
Yes. It is something consistent.
Yeah.
Well, doctor, thank you so much for your time. We appreciate it. And hopefully this is the first of multiple.
All right. Yeah. I'm looking forward to it.
All right.
All right.
Thank you so much.